Peterson. Um, so, as I said, it's my complete pleasure to invite Dr. Mark Peterson to join us this evening for our first part of our Midweek Matters deep dive into movement. Mark is an associate, actually, he's a professor at the Physical Medicine and Rehabilitation Unit at the University of Michigan. And his research focuses on understanding factors that influence health and life expectancy in people with disabilities. I'm sure there's many other things he does, but this is what I am just exploring with you from the bio. Mark's published so many papers, some of which explore health impacts and chronic conditions when having cerebral palsy in adults. Others have looked at the increased risk of mental health disorders among people with cerebral palsy and the higher risk most recently of the opioid prescriptions within the CP community in the US. We've also seen a great slide that Mark shares, which demonstrates the increased research into adults with cerebral palsy, increasing from 34 papers, over 10, 15 years ago, up until 93 papers a few years ago. So there's an upward trend, which is really positive. And from across the pond, he's a great supporter of our work and the work that we do at the charity, and works closely on research papers with Dr. Jennifer Ryan, one of our trustees, and a researcher herself specialising in cerebral palsy. He spoke at our Medicine and Me conference, which was held at the Royal Society of Medicine in July 2022. And Emma joined him on the same stage speaking at the European Academy of Childhood Disabilities conference this May. This evening, Mark's going to explore addressing the sedentary lifestyle as a person with cerebral palsy and the importance of repackaging movement, regardless of your level of ability, as a way of improving our long-term physical and mental well-being. Gives me great pleasure to welcome you, Mark. Over to you.
Thank you so much for that really, really generous introduction, Miriam. It's an honor and pleasure to be able to speak to you guys today. And as I said, I'd love to have this be, an open forum for discussion. I'm more than happy to talk about some research or personal experience. As you mentioned, I am a father to a 14-year-old boy with cerebral palsy, Marcus, who just celebrated his 14th birthday yesterday. So I have several hats that I wear, and that brings perspective that I think many of my colleagues perhaps don't understand or have. And so I certainly appreciate the opportunity to talk and share insights and also learn from all of you as well. So thank you again for the opportunity to join you. It's only 1:45 here in Michigan. And I appreciate you taking time during your evening to have a discussion with me. So, Miriam, I'm more than happy to answer questions or just kind of talk about my work, whichever would be most useful. I have no trouble talking. So if that's what you'd like, that's what I will do.
Yeah, I think what would be brilliant to start with is the fascinating articles that you've explored regarding the sedentary lifestyle, because I think that our community is always told you've got to exercise. We're all being told you've got to exercise, but the concept of exercise for somebody with a disability is a completely different interpretation, and the mainstream population, the mainstream community, and they've got lots of ways of doing it, and social media, etc., businesses help facilitate that. But I think that if we as a community can understand the importance of not being sedentary rather than the other side of exercise, it will help us give some more foundations to our motivation.
Yeah, absolutely. I think that's a really nice segue. I should say, although I'm a translational scientist, that means I do research in a number of capacities. My background and training is actually as an exercise physiologist. So my college education was centered on physical activity and exercise physiology. So, we have to distinguish between, it's really important, I think, first to say, most people don't do any exercise, at least in the United States. I don't know about the UK, but just participation in physical activity and exercise is at an all-time low, even though there are opportunities and apps and software and incentives across the board. Still, there are fewer than, I think, 25% of even adolescents are physically active at the level that would be considered necessary for health. And so I like to think of exercise in a little bit of a different way, because we've packaged it to be only one thing. And that has done a huge disservice to help people to understand the benefits of movement. And so the title here is about movement. And so I think we should think about the fundamental elements of movement first and foremost, rather than thinking of sort of what is the maximal of the amount that we should be striving for. So because we have preached that we need to maximize everything, everybody is avoiding exercise pretty much across the board, especially folks with cerebral palsy and other physical disabilities. So when I think about the way I like to couch what physical activity should look like, it is taking folks from being sedentary and starting to understand that anything that represents fragmenting sedentary behavior is a good step in the right direction. So because we've packaged exercise as being, it has to take place in a gym, it has to be with a personal trainer, it has to be with a certain attire, it has to be with certain supplements, almost nobody adheres to what the recommendations from the U.S. Surgeon General is, or the American College of Sports Medicine. So I have really changed the way my own personal belief system is, because if we can take a moment to think about what sedentary physiology is versus exercise physiology, we can do a lot more in the space of changing sedentary physiology than we can on the maximal other end of the spectrum to improve on sort of high-end physical activity or exercise. So most of my talks are on the basis of what happens to our body when we're completely sedentary, and those are all negative, as you can imagine. The multi-organ system deterioration that happens with high volumes of sedentary behavior is very conclusive in terms of the evidence, from bone deterioration to metabolic conditions to mental health disorders, and psychological outcomes. And so when we start to try to advocate for movement, what that means is we're not saying people need to take 10,000 steps or do 30 to 60 minutes of physical activity. We're saying is that if we can figure out a way to encourage folks to just simply stand up or move around in some form over the course of a day, several times throughout the day, that actually has a beneficial effect on physical health, and also mental health. There's a nice body of literature to suggest that reducing sedentary behavior actually helps with mood affective disorders like decreasing anxiety and depression. But it also has an enormous effect on metabolic and musculoskeletal health. That's the health of the muscle and bone. So I really try hard to preach or advocate for changing the landscape of what we are recommending to encourage reducing sedentariness, rather than preaching the maximalist. We need to do, this type of exercise on these days for this amount of time and for this dose, because what happens is nobody does it, and not even people without a physical disability are doing it. So it does a disservice to the community to say it has to look like this, when doing that means that no one's going to do it. Even among my colleagues who are very physically active, most of them don't get 10,000 steps a day. So I think we should just start advocating for, can we reduce our sedentariness? I mean, myself included. Can I stand up more often? Can I do a better job of taking little rest breaks from work and taking a walk, or maybe taking a walk with a colleague to have a work walk, rather than a sit down meeting. And the list goes on, and I can talk about different forms of exercise and different forms of physical activity, but I can't stress enough that we need to get out of the paradigm of all of the things that we hear about exercising and the amount that we need to exercise, because while those things are true, it's not a healthy message for any community, but especially this community, in terms of actually having some sustainability and not intolerance for what you're trying to accomplish and do. because exercise as it's packaged can be difficult and laborious and boring and painful. And so I'd like to try to change a little bit of that paradigm to suggest that it doesn't have to be those things.
That's really great, Mark. Thank you. And I'm just wondering if you could unpack a little bit more, um, just from a health perspective. You touched on the mental health aspect of movement and how that can help us, but you also talked about the non-communicable diseases around sedentary lifestyle. And I think that again, we hear about these being big issues in our population, but we don't necessarily always make the link. You know, we might think, oh, it's a genetic, it's in my family. We don't always make the link with our movement. And I'm just wondering if you could talk a little bit more about that.
Yeah, and the reality is we all face risk for non-communicable diseases, with especially with age. But in the CP population, and this extends to my own son, in the CP population, there's higher risk. So because of the nature of the condition, because of various factors that contribute to increased sedentary behaviors, there is an inherent risk for developing early onset non-communicable diseases. So these are all preventable, which is I guess the silver lining is what I'm trying to say, is that non-communicable diseases are diseases that are not infectious diseases. So they are caused by something that you're doing or not doing, basically. They're not exposure related. They are related to lifestyle, essentially, largely. And so because of the nature of the condition, cerebral palsy lends itself to higher sedentary behaviors. And as a result, there's higher risk for, take out of the equation the genetic component of diabetes, for example, which is only 2 to 3% of the explanation for developing diabetes. Behavior and lifestyle represents almost the bulk of the reason why people develop type 2 diabetes. So that can be unmanaged, glucose because of dietary conditions, or it could be as a result of physical inactivity for long periods of time. So another example is osteoporosis. Most of our clinical folks have signs of early onset osteopenia and osteoporosis, so low bone density. And these are also conditions related to physical inactivity. And so we can have an enormous impact on these by doing and stimulating the system in a healthy way, by doing activity, physical activity, movement, resistance training, for example, to help to stimulate the muscle, the bone, and all of the organs that are susceptible to non-communicable disease. And the brain is also one of those. So I have to say, I'm not a psychologist and I'm not a neurologist, but we have done some of the first and only studies between myself and Dr. Ryan in the world to show that there is increased risk for psychological and mental health disorders in CP. And we know that those are also things that can be affected by physical inactivity. And so the inverse of physical inactivity is activity, even if done at small levels and small doses. And that does go a real long way. That's the reason why there's a whole movement now that's coined exercise as medicine, because now doctors, actually medical doctors, are starting to prescribe exercise. And I can't, I'm fine. It's like, it's been so long in my career waiting for this day to actually finally happen, but it's happening. People are writing scripts for exercise and making recommendations for exercise. And I'm like, yeah, I've been saying this for like over 2 decades now, 3 decades. So thankfully it's finally catching on. And rather than prescribing a pill, we're starting to see people making recommendations on the basis of physical activity. So that's really good news. The bad news is exercise takes discipline, and exercise takes practice and habit and undoing bad habits sometimes. That's for all of us, frankly. So it's figuring out the best sort of avenue to get on the right track. And I say 100% certainty that is not doing the New Year's Day resolution, start exercising like a crazy person. It's start small and build over time, because your body does not respond that way. Your body responds to small incremental doses of stimulus.
Amazing. I've just had I'm just aware that we're talking about diseases and it can sound initially a little bit overwhelming. And what I just want to make sure everyone understands is we're taking you on a journey this evening, and we're not going to just leave you with doom and gloom, because Mark is like one of the most inspirational research people that I've heard speaking. So I know that that won't go there. But what somebody has asked in the chat, if you could give an example of a non-communicable disease.
Yeah, and I think actually to your point, I have had comments in the past, which is, wow, that's really depressing, this information. And I understand that that sentiment is loud and clear to me, and it's loud and clear and personal to me as well, as my son has had several fractures. Um, what I want to say is that, you know, not only are we able to advocate for ourselves, advocate for our friends, but we can also educate our ignorant doctors because frankly, I mean, the field is still so new with respect to lifespan health outcomes and health disparities facing individuals with CP. It's still considered to be largely a pediatric condition. And as Emma will say, there's more adults with CP than there are kids. So we can't continue to pound this notion that it's pediatric condition. This is a lifelong condition, and we have to treat it as such. And that's been my life's mission. Honestly, my whole career is now devoted to, you know, better understanding health outcomes in people with CP across the lifespan. So the examples that I can provide for non-communicable diseases are anything, essentially anything that's not an infectious disease. So you think of the common conditions in the United States that are related to something like, you know, obesity, for example, which would be cardiovascular disease, diabetes, even early onset dementia. There are a number of conditions that are related to obesity. The other conditions that are related to, that are really considered to be non-communicable diseases, are things like chronic kidney disease, bone disease like osteoporosis, you know, sarcopenia, which is a fancy word for just saying small muscles, muscle frailty, muscle wasting, that we typically would associate with old age, happens earlier in life for folks with CP. So think anything that's not an infectious disease like COVID, anything that's not infectious is a non-communicable disease. So that's a non-infectious disease of origin, of mechanism.
Okay. We're getting some really lovely things in the chat here. Courtney's posted some stuff about some nice infograms on non-communicable diseases. And Alex has said, at my local leisure centre, I'm sure there are fitness yoga classes you can join on prescription. So I agree it's a positive thing. So I think the social prescribing element, I don't know if they have that in America, but it is slowly gaining awareness of the concept of a GP referring a patient to do some more active, engaging things, whether it's physical or social engagement, which will help someone's well-being. Before I go on to any other comments, I've just noticed Sarah and Emma got their hands up. Sarah, do you want to go first because you had your hand up first?
Yeah, I want to know. In America, it's a lot different, isn't it? We have the NHS, which is universal healthcare, and is it an extra cost to somebody with disabilities? You know, having exercise. I mean, do they have facilities for wheelchair users? I mean, I can't exercise at all because I can't lift my arms or my legs. And so that's why I have put on a lot of weight. Is that, do you know, I mean, what happens when they get referred for exercise? I mean, I'm just saying, what's the structure like for people with disabilities over there? And like, do they have to pay for extra services like sometimes like people with disabilities get a discount in certain sports facilities and swimming pools? I mean, do they have like hoists that you go in the water? What's it like over there?
It's not good. I'll be honest with you. It's not sufficiently supported. So we have a healthcare system. I'm sure it's no surprise to anybody that is far inferior to what you have. And I understand that there are problems in virtually every country in terms of the healthcare infrastructure. In the United States, we have more of a capitalist approach where we have private insurance and then we have Medicare. And Medicare is only offered to individuals who are over 65 or who have a disability designation. The problem with Medicare, even though that covers an individual with a disability, it's elective. You can choose to have it or not have it, but it is poor coverage. The coverage that is represented through Medicare is essentially medical services rendered, therapy to a certain extent. Unfortunately, you would think that physical and occupational therapy would be covered without boundaries, but it's not. It's time. You have only a certain amount of time. And physical activity and recreational facilities are exclusively not included. So individuals are left to their own devices, so to speak, unless they fit another criteria. There are certain criteria like age. There are certain types of recreational facilities that offer discounts or free enrollment for people over 65. But if, for example, I wanted my son when he turns 18 to join a facility because he has CP and get services, I would have to pay for it. And so there's some problems inherent to that, because not only is it inaccessible from a facility standpoint, but it's also that the providers that are there don't know what they're doing necessarily. So a lot of the work that we're doing is trying to train the providers. And that's why I say, like, if you did anything from our conversation, going or turning around and telling your doctor, your primary care physician, what they need to know is a really important step with the advocacy piece. Because I'll tell you right now, most doctors don't know how to treat adults with CP. And that's why a lot of adults end up being seen by pediatricians in the United States. And I have a huge problem with that. So that's why I think that this is important.
Don't they have neurologists? Is that neurologists, people, that have neurologists, they know a lot about CP with, the brain, lack of oxygen to the brain. And I mean, I'm under a neurologist.
Yeah, neurologists know a lot about the brain, but they don't know anything about your bowel and bladder, bones, or endocrine system. So that's where the fragmentation between providers, the lack of coordination, is something that we're trying to figure out. I'm working very hard to create what I would say would be the first ever clinical practice guideline for adults with CP, because it's just that it depends on the provider you see. If you see a neurologist, they know nothing about what happens from the neck down, essentially. I mean, they have some idea what happens to your spinal cord, but not really. If you see a PM&R doctor, they might know something about how to treat spasticity, joint issues and pain, but they don't have any idea what's going on with your heart. And this is where we fall short as a medical community in terms of care coordination and continuity from pediatric care to adult care. And that is, we have to do something. That's what we're trying to do better, is try to figure out how to improve that coordination. But it starts with training these doctors to understand what they're seeing in front of them. It's not just limbs and joints and muscles. It's a whole body and a whole organ system that's affected. So I appreciate your question. I mean, there's a lot of things that I could probably learn in the US, could probably learn from the UK health system. And in Australia, it's done completely different. There's a disability health scheme that pays for transportation and physical activity and gym memberships. And so there are certainly models that are better than probably both of our societies.
Brilliant. Thanks, Sarah. I'm going to go to Emma next, as she's patiently waiting. And then we've got some more questions lined up for you, Mark.
Great.
No, you're on mute, Emma.
Sorry. It's really nice to see you. Thank you very much for joining us. I guess I wanted to pick up with what you were saying before around. So when we first met, what we were hearing was a lot of information about the increased risks of things like heart disease and diabetes, and as you say, the non-communicable diseases, and the increased risks of anxiety and depression in the community. And at that point, all we had was these kind of stark data about the fact that we've got all of these risks, and as you say, although it's really nice to hear that you think that we do it slightly better than you do it in America, I can tell you that most of us think that it could be done even better here, and that's what we'll continue to ask for. But when I met you, what I was able to understand as somebody living with cerebral palsy was actually that I could do something about some of those risk factors. And what you helped me to understand is that, yes, we're at increased risk of some of these things, but by moving and by being more active and being less sedentary, which I'm honest, I didn't really understand at the time what that meant, but that just meant moving more in my world. It actually started to make sense to me that actually I had more control over, so that to this point that we're giving really negative information. For me, knowledge is power, and if we understand the things that we can do, I think that's really useful. I don't know if anybody else did, but I recently watched a program on Netflix. They have a documentary at the moment that's looking at the blue zone. So they're looking at places around the world where people are living well into their hundreds, and they're living healthily, and they've got less non-communicable diseases. And they were looking at some of the reasons, and they looked at diet, they looked at lots of different factors, and the one common denominator between all of those places is that within everybody's lifestyle they are moving every day. So it's not that they're going to the gym, but it's like within their lifestyle they are much more active. So that made me think, well, these are people without disabilities. So if it's that important for people without disabilities, how important is this for people with disabilities? So I guess what I wanted to know is whether you had any tips. I know we all have a different level of ability and disability, but if you could say, if you could just do X or Y, it would make a difference. What would you say that would be? And I know I'm putting you on the spot, but I apologize, and I know Mark, so there we go.
That's okay. I don't mind being on the spot, Emma. So there is no answer, right? Like, there's no right answer to that question. It's personal. It's very personal. I would like to do something that somebody else would not like to do. And honestly, what I can't emphasize enough is that something is so much better than nothing. So even if you think it's insignificant, moving about just in your free living environment, your home, your workplace, with your pet, I mean, any movement, whether it be walking or not walking, any movement is actually using energy, right? Anything you do to move your body in any capacity uses energy. All right. We think of just lying down still as the baseline. Anything that's more than that is better than lying down or sitting still. And so I'm trained as a maximalist. I used to train professional athletes before I went into medicine and research. So my brain was conditioned to think of more is always better, and how can we optimize performance? I have had to completely change the way I think, because what we know is that most individuals, not just people with CP, but most individuals they're not high-end performers. So if we can think of how do we tailor physical activity recommendations for people that don't like to move or aren't moving a lot, that's the best place to start. And I will say, when you do something, it becomes more tolerable with time. The quick use of the excuse pain for not doing something is a perfectly legitimate reason, but actually there's a lot of research to show that physical activity can improve pain. So while I understand all of the reasons, whether it be time or work or family commitments, I often am accused of saying that physical activity, like education, should be the most important thing that is taught in school, more than math, science, English, history, anything. It should be physical activity and physical health, because it is really ultimately the most important thing in our entire lives. So it's really important, Emma, to stress that anything that's movement is good. I happen to really like resistance exercise because it improves not just the physical health of the muscle, but also the metabolic health of the muscle, and it stimulates bone. So if I were to say, what do I think is the most important form of exercise for people with CP? It would be resistance exercise, any kind of loaded resistance exercise, whether it looks like physical therapy or not, it doesn't matter. If it's resistive of nature, it creates a stimulus to the muscle that improves the metabolic health of the muscle, but also the strength of the muscle and the bone, as well as the connective tissue. So I can't stress enough that I think activity just in general is super important for all organ systems. But if you can find time, and perhaps if you need to find somebody that's an expert in the area to help design a program, resistance-based exercise is possibly the most important thing that you can do. It really is.
Amazing. Thank you so much for that question and thought process, Emma. I'm going to go to Nasli now. Nasli, welcome to Midweek Matters.
Thank you. I just want to go back to a point you were making quite a while ago now about the classes that you can join. I've noticed that with yoga classes that they have them for MS or fibromyalgia, but they didn't mention CP. Is that something to do with the fact that CP is more underfunded than other disabilities?
Yeah, I suppose so. I mean, we as a community are trying a lot harder to do advocacy, here in Washington, for example, to get improved funding. You have the NHS, we have a different system, and the NIH is our largest funding agency for research, and there is no line item at the NIH for cerebral palsy research. We're really trying to make a change in that. But yeah, so things like fibromyalgia and multiple sclerosis or autism spectrum disorders seems to garner more attention, and unfortunately, and interestingly, there's more people with CP than those conditions. So I think we can do better. So that's a great question.
Yeah, could it also be maybe that the other disabilities, one has a mental health issue, mental disability, and the other one's late onset?
Yeah, and there's a whole host of reasons for why, and it could be that some politician has a child with autism, or their spouse has multiple sclerosis as well. So things like that really make a big difference in terms of policy and way government works. I just personally, because I know what CP is, and it's a lifelong condition. We have an opportunity to do better. And again, I have to stress it not just 10 years ago, it was a pediatric condition. I mean, it is still considered by many to be a pediatric condition. So there's just a need for better information, better education in the space of not just public health, but public policy as well. So and I do think each of us is responsible for educating our own doctors, frankly, about these things too.
Just to come in there, I think one of the biggest reasons in the UK that you will find that those classes don't exist for CP is, just as Mark has suggested, is that to date it is being seen very much as a paediatric condition, and that we're just moving our understanding that it's a long-term condition, and therefore we would benefit from services. So we are further behind as a child onset disability rather than an acquired disability with the public awareness around cerebral palsy. And that's something that we're trying to change. And I think with a change of awareness, we might get a change in services.
Fingers crossed.
Oh, thank you, Natalie. Becky, can I invite you in to, because you've got your hand raised?
Oh, she's moved.
Hello.
Hello, nice to see you.
And you. I slightly different track and might be more of a British NHS thing than perhaps you're used to kind of thinking, but where I live, there's been quite a big push for social prescribing stuff, and for people to be prescribed exercise and other things, but it all happens during the day. And actually, if you're a person with a long-term condition who happens to work, you then have a problem because you can't access any of these things even if you were eligible for them within the appropriate time frame. So I just wondered whether that was a thing that happens in the States, and whether anybody has ever come across that or dealt with that, or what things have happened, and whether people have, or whether any of the research you've done has looked at, people have got well enough to be able to work and have then gone backwards because of the nature of being sedentary at work, or I'm lucky in that my job does involve some movement, but for some people being in front of a computer all day then stops them from being able to perhaps do some of those other things.
I can probably help with this.
Courtney, can you just let Mark answer first? Is that okay?
And,
That's okay.
and I have to say, admittedly and humbly, I don't have an answer. We don't even have a system in place in the United States, let alone a time that is eligible or not eligible. So I think that's a weird issue, that you have to come in at a certain time. And that's almost the pure definition of ableism in my mind. In fact, if you open the definition of ableism, it sounds exactly like what you just described.
Well, I think it's partly a bit like what you were saying before. From my experience, a lot of these things are aimed at either people who aren't at a level where they can work physically, or you were talking about people being able to access certain types of insurance if they were older, right, and therefore retired. And right. I think it's the same kind of principle without kind of looking at perhaps the wider scale, but I don't know.
Yeah, employment, the intersection of age, employment, and disability is interesting. And I have to say, what we have seen is a lot of folks they're becoming not employed because of the exact reasons why you just discussed. So they may have private insurance because they are employed, but they lose employment, and so they are forced to transition to Medicare earlier than obviously retirement, and it's a real problem. So keeping people employed, providing services and accommodations, it goes more than just for recreation, it goes for employment as well. And I do think there's a huge room for improvement in that space as well. It's something that is not solved at this point. And all the accessibilities that have been made are so inferior to what actually is needed for the function and thriving in real life that has to happen. So what you're describing is exactly the real life problems that people have, and it's just that it's not there's no impact in terms of policy at this point in the US. I mean, we're doing a lot in the space of accommodations for employment and adaptive sports and adaptive recreation and healthcare services, but it's way behind from what it should be. So just starting with, if you think about sitting in a chair all day, I'm sitting in my chair right now, sitting in a chair all day. If there is something that you can do that would help to like ping you to get up or move or go get a water or a bathroom break or something periodically, even if it isn't required, I would hope that your employer would be understanding that is something that is for your health and benefit, and ultimately for their health and benefit as a workplace. Thanks for that point, though.
Thanks, Becky. I'm going to go to Mary Elaine, who has been trying to work out how to raise the hand on the screen, and now she's done it. So, Mary Elaine, if you want to raise some of the points you were raising in the chat. Are you there?
I've lost her.
Oh, she's gone. Okay. Well, when she comes back, we will go straight to you, Mary Elaine. Becky, sorry, Courtney, did you want to ask your question?
Courtney, I think you're on mute.
It's not a question, it's a comment of what you said right at the start. and this is kind of me kind of going from two sides. Earlier, you were saying, well, I'm sorry that it seems very negative and the question, some of the facts that we were talking about. And to be honest, I don't think we should ever apologize being negative or disgusting or realistic about any of these issues. Like you said, and knowledge is power. But even though knowledge, it, we don't realize the reality of what we've got to live with. And disabled people or anything, not just our with disabilities, we can't inform or support other people who are going through this with no support. I always say that realistically, it's scary and you may not want to think about some of this stuff. But the way I see it is that if we don't know this information, we can't then put our armor on. And if we don't know this knowledge as armor, we can't then protect other people. And that makes sense. I don't know if that makes any sense whatsoever. It's kind of blur in my head, but I just want people to understand that it's not us being negative, it's us putting the armor on through knowledge, understanding, and support. We have the armor that we can then pass on to other people.
Yeah, no, I agree. As I said, I've had comments in the past from mostly parents, honestly, that like, I mean, this information is scary, depressing, you know, and I understand. I understand. I have my son has CP. I understand. But what happens is when there is no information, then, and Emma will say this is very much the way everyone feels, is you fall off a cliff after the transition from primary pediatric care to adult primary care. And that's because there isn't the information. So now that there's information, you know, we as a community have, it's not a responsibility, but I think it's an opportunity rather to do something about what's happening here. Because if we wait for the medical establishment to catch up, it may be too late for some folks. And so I really believe, as you said, that knowledge is power. And while we want our clinical colleagues to be up to speed on all of the information, they're human beings and they were not trained on this in medical school. So we can do a good job of educating and me writing lots of research papers that hopefully somebody will read. But I do think that as a community, we have an opportunity to work together to advocate, not just to our clinical providers, our public health officials, but also policymakers, so that we can make sure that everybody's taken care of with the kind of care that would be expected among other complex conditions. So a perfect example of really good care, and this will come as no surprise, is in pediatric oncology. So what happens in pediatric oncology is that there are an enormous team of doctors that consult with one another about the care of an individual. And that type of coordination of care is extremely important for other complex conditions. And CP is, frankly, is a very complex condition. So in my personal opinion, having a medical home of sorts where doctors talk to each other about the care of individual patients and talk across disciplines is extremely important. So we aren't there yet, but harnessing the power of our community will be helpful for improving that advocacy and improving the education of our providers. So I appreciate that comment, Courtney.
I'm going to just move the direction slightly, because we've been there was a couple of comments in the chat around pain and movement, and Alex gave a really lovely sort of history regarding Alex Foster, regarding her experiences. And Alex, if you would like to explore that with us. That would be really an interesting direction to take it in.
Sure, yeah. Hopefully I won't be too long-winded, but I'll try my best to be concise. Basically, I'll read most of what I put in the chat. So I've got kind of more into exercise and physio in the last year or so after moving away and living independently from my parents, being lucky enough to do that. And I think I noticed since the pandemic that my mobility has kind of really decreased, and as a result of not moving around as much. Because obviously we were all working from home, and now I work from home pretty much all the time. So I thought, oh, maybe I should start doing something about this, especially as I was getting into my 30s. And I was thinking, right, well, if I don't start moving soon, I'm probably going to just get progressively worse in terms of my mobility and that sort of thing. But I realized when I first started getting back into exercise that my body really reacted quite badly to it. After not really doing much exercise, quote unquote, or physio really since that stopped at the age of 16. I think a lot of people, hopefully in this group, may have had similar experiences of that kind of care dropping off as soon as you reach that age. And at the time, I didn't want anything to do with it because I just wanted to be like a normal teenager like the rest of my friends and kind of distance myself from it. But now obviously I'm a lot more accepting of my identity as a disabled person and a person with CP. So sorry, I'm waffling a little bit, but essentially, yeah, I had a lot of bad piriformis pain and back pain where I think my body was reacting to parts of it moving again that weren't moving before. And so I just wondered how easy it is to overdo it after a long time not moving, and also to kind of prevent that kind of thing happening. How would you think about movement and exercise as something positive and fun, and not something that's more like a chore or something overly medical, which I think I tended to view it as for that time when I wasn't doing it, if that makes sense?
It makes perfect sense, and it's something that I think resonates with everybody in this call.
Yeah.
Because I have said and said again that individuals, they don't want to do PT, they don't want physio. It's not something that they remember fondly, I guess, so to speak. And that's okay. I agree.
Yeah.
And what I would say is that, to answer your first question, it's very easy to overdo.
Yeah.
It's very, very easy.
Yeah.
It's very easy to overdo in the non-CP general population. So of course it's very easy to overdo. And that's why I again, I really advocate for really small doses to start.
Yeah.
And if you can figure out something that you enjoy, I have one colleague that's at University of North Carolina, who does nothing but aquatic exercise with people with CP. That's great, except if you don't have access to water, that makes it very difficult. Yeah. So I have to say, water is a phenomenal means of exercise, because you can unload, even for folks who are totally non-ambulatory, completely non-ambulatory. Water represents a medium by which you can ambulate. You can move limbs unloaded, because of the buoyancy of water relative to air. You can do a lot more in water, and it also creates a 360-degree source of resistance too. So if you wanted to do some form of aquatic-based therapy, it's easier, and it's also more tolerable typically. Again, that's only really useful for folks that have access to water. So if you don't have access to water, my personal take is that if it's fun, just do that. If I can get my kid to be physically active and he doesn't realize it, because he's walking up and down and pulling himself up and down a park playground, then I'll let him do it for hours. And that's exercise. He comes out sweating and doesn't realize it. There's a lot of indoor facilities here. It's because of the weather. It gets very cold there in the winter, where now they have trampolines and play parks and things like that on the inside, and facilities here in the US and in Michigan anyway, that we go to on a pretty regular basis, because he doesn't know he's getting exercise. I know he's getting exercise. He's just having fun. So whether that is, kayaking or, biking or hiking or doing something outdoors, I also think outdoor activity creates a positive feeling as well. There's quite a bit of research on doing stuff outside that has positive mental health benefits too. So I agree with you. I love my physical therapy and physio colleagues, but most adults with CP, they tend to not want to do physical therapy or physio. And so that message that you just said is very common.
Thank you. Thanks.
Can I just come in briefly with that, because actually that was a question that I was going to ask Mark, is that part of the work that we're starting to do here in the UK is to talk to our paediatric friends and colleagues, and particularly in physio, about positive experiences, or that physio doesn't just have to be physical therapy. How, and what we saw during the pandemic when we were running groups with people to help them, basically to help them to manage pain and to support them with some decline that they were experiencing because of the pandemic, that we found that people who'd had positive experiences or had access to activity that wasn't physiotherapy in their childhood were much more able to access those when they got a bit older. I guess, you know, if we were talking to our paediatric colleagues, what would you say that would be important to say to them about setting up those healthy habits for adults?
Yeah. I think that's such an amazing question, actually, Emma, because what we know about what happens to adults is something that doesn't start in adulthood. All right. So these are lifelong lifestyle and behavioral things and habits that are formed in childhood. So, you know, what we know about physical activity or exercise, for example, is that if a child does exercise in childhood, obviously as a child, it tracks into adulthood. A child that does no exercise or is forced to do only physio that isn't fun tend not to do any exercise or physical activity for enjoyment and as an adult. So I have had this question before. Why don't you care about children with CP? Obviously, that comes from somebody that doesn't know that I have a child with CP. So my answer simply is that if we know about what happens in adulthood, it should translate to what we start doing in pediatric care. So pediatricians should really be talking to parents and caregivers about healthy lifestyles, and not just physio, and not just Botox, and not just, you know, hips and back and joints. It should be about what happens later in life so that we can lay the foundation for healthy behaviors early in life. Here's a really good example. This is maybe the best example I can think of. Children with CP typically are underweight. They're at higher risk for being a very low body weight relative to the normative reference standard child. So age and sex matched. So what happens, at least in the United States, and I would say it probably happens in a lot of places, is that a pediatrician will tell a parent, your child is in the 5th percentile for body mass, and you need to feed this child. So what happens as a result of that is parent is left to their own devices to figure out a way to increase the number on the scale. And so parent feeds child with a whole lot of calorie-dense foods that are not healthy. So as you could probably imagine, body weight goes up, but body weight is not healthy weight, all right? Just because body weight goes up does not make it healthy weight. So we have to do a better job of teaching our pediatric colleagues that while a child may be underweight, that does not mean we want to reinforce increasing body mass just for the sake of increasing body mass, because you're putting that child at risk for prediabetes and metabolic syndrome. So I think it's a really important, to your point, that we start talking to our colleagues in pediatrics, and not just our pediatricians, but our pediatric physical therapists, that how do we translate what we know from adulthood into healthy behaviors early in life that will hopefully forestall or totally prevent some of these non-communicable diseases that we know happen in adults. So super, super good point that you made.
Thank you, both of you. That was amazing. I'm going to go to Sam. Sam, welcome.
Hi. So I know women know me quite well. I'm a personal trainer with CP in the UK, and currently I'm virtually out of action because I have a bulging disc L5S1. So when obviously this is my job, I've been trying to research the prevalence of lower back pain with adults with cerebral palsy. I know it can be quite common with people that are like ambulant with CP in their 40s and 50s. You know, I know there's quite a few people in the UK that have had the bulging disc, this type, the outright visual bulging disc as they get older. Has there been any research done in this area or not? Is my question. Is when I tried to search for it, I can't find any.
Is there research specifically on disc herniation in adults with CP? Is that what you're asking?
Yeah, basically, yeah.
There isn't. There isn't. So what we know is that adults with CP have high risk for just musculoskeletal conditions just across the board. And that's a very blanket umbrella term for bone health, muscle health, joint and ligament health, tendon health. And that includes the spine, obviously. But to my knowledge, there has not been one study done on disc extrusion in adults with CP because of CP. I would imagine because of issues related to curvature in the spine being higher in individuals with CP, there's probably a much higher risk for disc herniation, but there just hasn't been any studies on it. What we can draw on studies from the general population about like the efficacy of spinal fusion surgeries and things like that, which a lot of our patients have had. Maybe you've had spine surgery yourself, to know whether or not that's a choice to do or not is kind of a personal choice. Some people don't have a choice. They're totally debilitated by the extent of the extrusion. And some people are able to do physio to actually compensate for the herniation itself, to strengthen the muscles around the sort of local area of the spine that helps to support the spine. But that's actually a really good question. Something I hadn't thought about is that we've done bone health studies and we've done kidney studies associated with bone health, and we've done fracture studies here at Michigan, but I've never actually thought about disc health, spine disc health as a function of that. But it's obviously very, very important and can be a major source of back pain and sciatica, for example. And I don't know if you're experiencing symptoms of sciatica, but that's like no fun at all.
It's the worst pain I've ever had in my life. I can tell you that now.
And have you spoken to your primary care or?
Yeah, I've seen a private spinal consultant. I had to go private because the NHS, I've had no luck at all. So we've gone private. So I've had a nerve blocker injection, which has not completely worked. It's helped me walk a little bit better. But the spinalist is one of the best in the UK. He said we had to go through that route because he didn't know it's going to work or not with the CP as well. So he had to try it to see. And then he told me to rest for 4 more weeks, and I got to go back and see him in another 4 weeks to talk about other options. Yeah. So it's about, it's not drawn out, but it's been a lot quicker than the NHS. Because I just had my first appointment in the NHS, and it was so bad that everyone would probably shock and cringe about what I went through with them. So I'm quite glad that I skipped. I've gone 3 steps more in the time I had my first urgent appointment with them. So, but yeah, it is the most painful thing I've done. And because my spinal surgeon's quite clued up about CP actually, and he's asking me questions, it just got me thinking, and I started to do research about it, and I haven't found anything. So yeah.
I on one hand, I'd like to say I'm so annoyed. There's 2 things here. I want CP to be the most important thing on every doctor's mind. Okay, there's one. The other thing is I want doctors to stop treating people as CP is what defines them. And I want them to be people and humans that have organs and have bones and have, brains and everything else, rather than going, oh, it's CP, it's your CP, it's just your CP. Because that's what happens often is somebody will like, well, it's your CP getting worse. No, it's not CP getting worse. That doesn't happen. So even though we say CP is a non-progressive condition, we all have progression and physical deterioration. So you just happen to have something that happens in a lot of people, which is a disc extrusion, and it has to be treated. It shouldn't be about CP. So I'm glad that you took matters into your own hands, although that's really unfortunate because it costs more money to have a private, doctor. So that's just the reality of what you did. And I think that's the right decision. But it's BS in a way because your normal doctor should be able to say, like, you have a disc issue, let's treat it. Now in the US, what happens is because everybody has back pain in the US, they got really picky about just ordering up MRIs left and right because those cost a lot and people were taking advantage of the healthcare system. So everybody started ordering MRIs and those are reimbursed by insurance until insurance started saying that we're not going to cover an MRI is just out of routine care. So people have to go through even excruciating back pain. They have to go through 4 to 6 weeks of physical therapy before they're even eligible to get an MRI. So thankfully that wasn't the case for you. I think
look, I had to pay for my MRI because I couldn't get it on the NHS because I had to, because I could go to the toilet myself, I couldn't get an MRI, so I had to go private for that as well. And
well, you need to do a better acting job than it. I'm just kidding.
Look, this is my job. I want to be back to my job as quick as possible. That's what I gone private for. So if I just in an admin job, I probably wouldn't have gone private. But because I'm in an active job, I need to get back to it, and that's why we had to take this route, basically. But yeah.
Well, I'm glad you did, and I hope that, I mean, if the injections weren't effective, I hope that they're willing to consider other options for you. And, stay diligent on that.
I am. Yeah. Thank you.
And Sam, I just wanted to say that you've just summed up in this short conversation the issues that we're all dealing with, and I love the way, Mark, that you summarised the fact that that we want our clinicians to acknowledge our CP. One clinician that I've spoken to always says to me, it's the neurology stupid. When I say, well, why is this happening? So we want people to understand that intervention is going to be in that the underlying cerebral palsy is going to have an impact on the way we present. But also, we also want to get them to treat us like people who have healthcare needs that they need to treat individually. I've never heard it said like that, Mark, but I think I want to clip that and then just take it around with me. So thank you. And I wish you better, Sam. I hope that that the block helps a little bit.
Thank you, Emma. Hopefully.
I want to go back to the chat because we've lost Mary Elaine. She's actually also on auntie babysitting duty, which is why I think she had to drop off. But she put some points in the chat so that when she's finished her duty and she can watch this back, then she'll get the answers. So you've all touched on bone health, which was really helpful. And Mary Elaine posted a question around her around osteoporosis, which is something that you mentioned briefly at the top of the talk, and I think that what would be really useful is you've talked about loading bones and muscles and resistance exercise and that effect, how that affects positively the bones. But if you're in a wheelchair, what are your thoughts around weight bearing experiences or movement experiences so that we can be mindful of the osteoporosis that, especially the female population will have a higher propensity earlier on in life to get through as they go through menopause?
So my thought is that loading the bone, especially the axial skeleton, which is the lower extremities, is extremely important. The number one sort of sites of injury or fracture are the distal radius of the wrist because of falls, and then you're basically the ball and socket joint of the hip, and then of course the spine. So lumbar spine is a major area. And so loading is important even among non-ambulatory individuals, people who are they're non-ambulatory, completely non-ambulatory. Finding ways to load the lower extremities, to load the core is really, really important. We even do this in our spinal cord population because the significant atrophy that takes place in the body after sustaining spinal cord injury is profound, and much more so actually than CP. So we have creative ways to get people out of, obviously it's therapy and intensive, but we have ways to get people up and loaded for periods of time so that they are standing. So folks have standers, and I know many folks with CP have standers or chairs that allow for loading, periods of loading in an upright position. And that's to me, it's very important. Obviously, I said something about pool work and aquatic exercise. The only problem that I have with that is that there is no real axial loading with aquatic based exercise, because it's by its nature, it unloads the body, right? Doing anything that unloads the body is kind of counterproductive for bone health. And so if we can create ways, even creatively, to load individual muscles and also the entire body by getting up, and with various means of getting up, then that is really effective for loading the axial skeleton and also actually stimulating the muscle as well. So, any kind of like stander or therapy-based passive standing is super helpful for individuals for not just bone loading but also muscle recruitment too. We did a study with some folks in the Netherlands where we moved children actually with CP from a totally supported seated position, just sitting on a physio ball, so an inflated ball, so still seated. And we did EMG recruitment of basically looking at muscle recruitment, and showed all of this muscle recruitment that took place just simply by sitting with a little less support than they were in a normal chair. So there's creative ways to do this without causing a lot of disruption, and without it looking like some crazy therapy or exercise that is not attainable. So simple alterations, perturbations, things that cause your body to have to support itself, for example, instead of having all of the supports in place that create comfort. If we cause a little discomfort, that can cause a lot of improvements in stimulus to the muscle and actually loading to the bone. So the problem also with osteoporosis is that, at least in the United States, it's not something that's usually screened for until the age of 50. And I will say that osteoporosis, the process by which osteoporosis takes place, occurs long before 50. And that's in every person, all right, including people without CP, women without CP. So I have always really tried to advocate for, getting early screening, taking preventive measures in terms of your diet and physical activity. But I don't know if that's a problem in the UK, but insurance reimbursement for osteoporosis screens is an issue in the United States, because if you're not 50 and you're a female, you're not getting a DEXA scan, basically.
And this is the very conversation that I had with my GP and GPs when we did GP training, that on the NHS currently there are several conditions that have been recognised as needing DEXA scans earlier, and that there are risk factors for osteoporosis, but cerebral palsy is not one of them. And so that is one of the things that we've started to talk about. So thank you for reinforcing that. This is something else I wanted to also bring up, slightly unrelated, but just slightly going back to pain. And we've talked about how exercise can cause pain. One of the biggest reasons that we get calls on our helpline is people talking to us about pain. So less, and also speaking to some of the clinicians up at Queen Square that have started a service, they said to us that what they thought that they would get when they started the service is really lots of people talking about a decline in mobility, but actually what they got was lots of people coming to talk to them about increased pain as they got older. I thought that maybe you could just expand on your knowledge about how we can use exercise to support pain rather than cause pain.
Yeah, exercise, the actual act of exercise is painful for a lot of people. It's painful, especially if done intensely. It's more painful for people with CP due to especially spasticity, joint contractions, contractures, and other issues like weakness, ataxia, postural issues, spinal issues, disc herniation, things like that. there is no doubt about it that there is some discomfort that comes with physical activity and exercise. There's no question. The way I like to sort of describe the benefits of exercise for pain reduction is very similar to how I would say exercise is useful for weight reduction, which is it doesn't cause anything to happen in the immediate time. It's not about what happens the moment you are exercising. It's about how stringing together days and days and days and days of exercise can contribute to the net result that you're looking for. And so pain, the experience of pain perception during exercise, while is true, the actual act of exercise for pain reduction over time is something that has been studied now pretty well. And there is a good amount of evidence to show that actually exercise reduces spasticity. So if we have, even though it hurts while exercising, if we have the ability to use exercise as stimulus to the muscle to then create a scenario that there is less spasticity to that muscle in the long term, we've basically and inherently helped with that problem. And so I understand that some forms of exercise are more painful than others. Look, I think running is the most painful thing in the world, but so I don't do it. I don't like running. But if we can figure out, ways that we can do some exercise that's not going to injure, we're going to be in good shape. We can do things that may be uncomfortable but aren't causing damage. That's, I think, the distinguishing thing that we have to make, which is what is uncomfortable and what is damaging. We don't want to do anything that's going to cause damage. And so exercising and doing a lot of rotational stuff on a bad disc is not a good idea. But doing some resistance exercise or doing some movement and movement therapy, doing aquatic-based therapy that while it's uncomfortable during the actual session may cause relaxation after the fact. The other thing that I'd like to point out is that people that do more exercise tend to have better sleep hygiene and sleep habits. And so we have done a huge amount of work lately on the use of sleep as a primary preventive intervention for pain. And it's a remarkable, people who have chronic overlapping pain, if they sleep better, they have less pain reported. So if we can do something to improve sleep, and non-narcotic solutions to improving sleep, we can actually have a huge effect on pain too. So the kind of triangulation between good sleep hygiene, physical activity, and proper nutrition really does help with pain management. And I'm not discounting the fact that there are other means to treat pain. There certainly are. But sleep and physical activity can really help with pain management.
Thank you, Mark. I'm going to bring Becky in. Becky, would you like to explore the points that you put in the chat a bit more?
Yeah, real. I just had thoughts about something that's really impacting me at the moment, really. And funnily enough, it started a bit like Sam's with bulging discs in the back, but also impacts onto other parts of my body as a result. So I wondered about your thoughts on how an initial problem in one, say, joint or muscle can then, I often find, because of pain and spasm, not always, but the pain and spasm cycle, the tightening up, and then you end up with another problem with another joint and another joint sometimes. And I just wondered about your thoughts about that and preventative measures, really.
Yeah,
thanks.
I mean, that your point is such a good one. There's a compensation effect that happens when there's pain, or for example, if somebody has an injury, and then they have to do their gait changes, the way they walk changes, the way they sit changes, and then all of a sudden you've created another problem because you've compensated for the fact. So there isn't a solution, so to speak, that would prevent that, except that I would say trying to, again, I hate to constantly go back to resistance exercise. If we did nothing but walk, every single person would develop back pain. All right. If we did nothing but just say, let's go out and just walk. Well, if we did that, that would be good for our health, but we'd all develop back pain and probably foot pain. So what do? We need to come up with a strategy that targets some of the muscles of the low back and the core to prevent that from being an issue. We need to stretch, for example. There are muscles that change if we sit all day, and those hip flexor muscles pull on the lumbar spine. So I know for myself, if I'm writing a grant and I don't stand up for 3 weeks, except for going to and from my car, I'm going to have back pain. I will have back pain because the muscles of the hip flexors, psoas, will tighten up, and that directly pulls on the interior aspect of the lumbar spine. So if we have a way, either passively or actively stretching the hip flexors, and I will say our glutes are our worst enemy too. Every single person has tight glutes, tight hamstrings, and tight psoas. So if we can figure out a way to stretch some of those muscles and simultaneously do some strength training of all of those muscles, a lot of our back pain goes away. And that's for myself included. If I start having back pain, I know I've been neglectful of some of this. And I think that you're 100% right. That compensation issue is something that happens to a lot of people. And figuring out a way.
You kind of feel like you're running out of, you've got one, but then you've got two, but the other one's working harder. You're running out of joints, to rely on, But I think, that's a really interesting point as well, that it affects, everybody. There's a sense that, if for us that and some will and some won't, but the crouch gait and the impact of that, and knowing that that's probably putting extra strain on there, but actually, it's
Can I also make a point? And to your point, and I just thought of this, we as researchers and clinicians have always, until about right now, have always tried to advocate to ambulate as much as you possibly can. And that has been the message to patients, is we need to get people active. We need to get people walking. And while I understand the sentiment behind that, what we have caused is a lot of issues, like you're describing. So if I'm telling you, go with your crouch gait everywhere you can go and avoid any kind of assistance, what I've effectively done is told you to ruin your back. I mean, that is really what
Yes, oh, sorry, I shouldn't interrupt. But that's my exact experience of knowing that the advice is walk, because sitting or being inactive will not help you. But actually then in your mind thinking, but I know I'm then wrecking, you could say, parts of my body by doing that, because you're not walking with a normal gait. So where do you go? And so
so I think
I wonderful that you've got some positive ideas to help that. So thank you.
Yeah, intentionality is a big thing. I think rather than say we need to tell all of our patients they should be walking to and from everywhere they go is not right. That's not right. I agree that we need to advocate for activity and movement, but we're doing it at the expense perhaps of the structure of the body. And I think that we have to have more intentionality and more precision with that recommendation. So I appreciate you actually bringing that up.
And can I just add on to that, Mark, as an adult neurophysio, I think that what we find is that when adults need to give their bodies more support, it's very difficult for them to not see it as a failure, not see it as they've let themselves down, because they've spent their pediatric years being told to get up, get moving, be more independent, be less needing of extra support, and just reinforcing what you said. What it actually does is set in this internal ableism that occurs within people with physical disabilities, which I understand why our pediatric colleagues do that, and I understand why parents do that. But then there's decades and decades of adulthood that needs to be worked through. And going back to Emma's healthy habits, I think we need to just look at the bigger picture as a lifelong condition, and what happens over that trajectory.
I think you're making a point that it resonates personally for me, which is like, as a parent, I want my kid to be normal. I want to make him do the things that look normal. And so that's the sentiment that a lot of parents have, which is understandable, but at the same time, with improper biomechanics and with improper gait and ambulatory movement, there's definitely going to be some wear and tear. And I think that's important to stress, that if we could create intentionality behind our recommendations, and rather than just the blunt instrument of saying you need to walk, we would have a much better outcomes. We'd have better outcomes. We'd have less pain. We'd have less issues with lumbar spines and feet and hamstrings and, you know, all the things, knees. So I'm really glad you guys brought that up, because that's something that's really important too.
Yeah. Oh, well, thanks, Brad, because you really summed up. Yeah, a lot of you really summed up a lot of thoughts and feelings, certainly on my part. I don't know about others, but thank you, much appreciated.
I'm just aware of the time. It's just gone 8 o'clock, and we do normally wrap up at 8 o'clock. I've also noticed that we've got 2 people with their hands up. So if Mark, are you able to stay for another couple of minutes?
Sure, no problem. Happy
Okay. Okay. So Sarah, do you want to go first with your question or point?
to.
Okay. When Sarah's ready to come in, we'll go to Becky first, and then when Sarah.
I'm here, I'm in.
Okay. Go for it, Sarah.
As I said before, what are the facilities like for wheelchair users, like swimming pools and gyms? Like to me, like when I used to go swimming, we had a hoist, you know, where you put your body in a sling and it alleviates, and you get on a chair and you get into the pool, and you've got equipment, especially in public pools, because you've got equality that for public amenities have to be catered for all. So what are the facilities like in leisure centres and swimming pools for people with disabilities?
Are you referring to what's going on in America, Sarah?
I'm saying about how when I was swimming, we had, you know, I used to go in and have hoists and.
So you know what I'm going to suggest, Sarah, because we've got a fantastic month ahead of us of exploring that. I'm going to make a note of that question, and then we can roll it onto, you know, each week as it goes on, because I think it's a really valid point that you're raising. Becky, what was the point you wanted to raise?
Oh, mine was more of a point, and it was going back to what we were just talking about whether we get people to move, or how we get people to move, and whether we always encourage them, if they are able to be ambulatory and to walk. And actually, as somebody who that happened to me, as well as the other Becky, I just find it interesting. I know the previous months before the summer, we were talking about independence. I think it's interesting about how we now, independence was considered, when I was a teenager, was considered to be about being able to walk and move in the way everybody else did as much as possible. That would make me as independent as possible, whereas in actual fact, I'm sometimes more independent when I'm in my chair, because I can do stuff. And it's actually about trying to allow people to have the opportunities to work out which way, what forms of movement allow them to be the most independent and able for as long as possible. Maybe something we need to look at as a bigger picture. So it wasn't really a sort of question, but it was more of a sort of point. And it's something that, as a 30-plus-year-old with CP, is something that I'm only now being able to explore and look back on and say, actually, at the time, that wasn't, you know, all these things that, making you more independent and more able wasn't necessarily what was happening, but that's what everybody, including me, thought they were doing for the best.
I'd say that's
research projects, Mark.
Still true today. So I agree with you. That paradigm needs to be kind of flipped in order to help with independence.
Mm-hmm.
I'm going to give the last question to Tom. I'm going to read it for you, Tom, because of timing. But Tom's asked, what would you say we could all do to help the cerebral palsy community? And I'm going to kind of extend that within this scope of the movement experience, as in physical movement, but also whatever general experience you've had as a researcher working within the community and a dad.
Oh man, that's such a hard question. It's such a good question because I've worn so many hats, and I mean my story is so different from other people, that I've done nothing but research, and now I've gotten to a point in my career where I want to see actual change happen, not just in our clinical environments, but I want to see change happen in public health and public policy and healthcare infrastructure for people with CP and funding for people with CP. That I have started doing much more implementation work and much more advocacy work. And what I have learned is that outside of a small number of organizations, this organization being one of them, and some national organizations here in the United States, there aren't as much as you would like to think in terms of advocacy groups doing work in the space of trying to change. So I think if you wanted to become part of a community, this is a great community to be in, this forum, this group. And I think if you can assert your voice in a way that can be heard by not just your colleagues with CP, your peers with CP, but your clinical providers. And then for us, we're trying to convince Congress to enact, some legislation that will improve funding for people with CP and research for people with CP. Those are the types of things that are actually going to make change. As a scientist, I have to do research. That's my job. My job is to do research. I'm impassioned to do research for various reasons. Some of them are very personal, as I mentioned. But I also truly believe that this is a worthwhile thing to do for improving lives of people with CP. But I can only do so much. As a scientist, I can only do so much in terms of what my research sort of scope is and reach is. I really think that the next sort of most important thing is this dissemination of knowledge to ourselves, but also our clinical colleagues, our clinical providers, and then policymakers who, frankly, I don't know about politicians in the UK, but our politicians are not the brightest people in the world. I don't know if that's different in the UK, but we have to really do a lot in the space of like helping for folks to understand what these needs are. Because there's pet areas that people have that don't end up representing, real need. So I'm trying really hard, and I think if you can work with Emma and Miriam, I think it's a great organization to help to advocate for what's necessary and what's needed. And I appreciate the opportunity to talk to you guys.